Welcome to the Rad Onc Smart Review GU Cancer Series.
Glad to be here as always.
Yeah, so today I want you to imagine a scenario. You cure a 29-year-old man of a highly aggressive cancer. You shake his hand, you send him out the door with a clean bill of health.
Which is an amazing feeling,
Yeah,
right?
totally. But then you realize your so-called cure just handed him a 50-year sentence of premature heart disease, maybe permanent infertility, and chronic pain.
Yeah, it's the ultimate double-edged sword.
Exactly. And that is what we are dissecting today. We are focusing on episode 22, testicular cancer, but we are looking at it through a very specific lens. We're talking fertility, toxicity, follow-up, and failure patterns.
Because, it's a profound paradox. If you look back at the history of oncology, before the 1970s, metastatic testicular cancer was basically a death sentence.
Right. The mortality rate was just astronomical.
Yeah, it was. And then Lawrence Einhorn and his team at Indiana University brought in cisplatin-based chemotherapy. And overnight, they turned a universally fatal disease into literally one of the greatest success stories in the history of solid tumors.
It's incredible.
We see cure rates now hovering around 95%,
Yeah.
even for advanced metastatic disease. But that very success has created this massive, decades-long second job for us as oncologists.
Yeah, the first job is curing the cancer, which we do incredibly well. But the second job is managing the survivorship of these guys.
Right, because we are talking about young men, usually in their 20s or 30s, who are going to live another 40, 50, or 60 years.
Yeah, so the metric for success can't just be a 5-year overall survival curve anymore. It's, did we protect their ability to father a child? Are we catching relapses without drowning them in unnecessary ionizing radiation from decades of CT scans?
Exactly. And crucially, how are we minimizing the long-term devastating costs of the toxic treatments we give them?
Right. And when you are in clinic, you're not just treating a histologic diagnosis, you're treating the entire trajectory of that young man's life.
Which is why this topic is so incredibly high yield for your oral boards.
Hmm.
The examiners are going to test your understanding of the underlying biology. They're going to push you on fertility counseling.
Oh, absolutely.
And they will definitely test your knowledge of the long tail of late effects.
So let's ground all this abstract biology in a real clinical scenario because, that's the best way to untangle it.
Always. Let's hear the case.
Okay, so you are sitting in your clinic right now. You're seeing a 29-year-old man. He is exactly 14 months out from a radical inguinal orchiectomy for a 3.2 centimeters pure seminoma.
Classic.
Yep, bread and butter. His pathology showed a T1 tumor, so confined to the testes and epididymis without vascular or lymphatic invasion. His post-orchiectomy tumor markers, so the alpha-fetoprotein and beta-HCG, they normalized perfectly. He had a negative staging CT scan of the abdomen and pelvis, no enlarged retroperitoneal lymph nodes. And because he had stage 1 pure seminoma, he wisely chose active surveillance.
Right. Avoiding adjuvant therapy.
Exactly. So now he is sitting in your exam room today, 14 months into this journey. He feels healthy, but he has 3 very specific questions for you.
And I bet those 3 questions are going to drive the whole episode today.
They really do. Question 1, when can my wife and I try for a baby? Question 2, how long do I need to keep getting these scans? And question 3, my older brother also had testicular cancer. Am I at risk for anything else now?
That right there is an entire clinic visit. We've got fertility, follow-up logistics, and systemic toxicity.
Let's start with the baby question, because that's usually the most emotionally charged thing in the room.
Well, without a doubt.
When can we try for a baby? To answer this, we have to clearly separate baseline fertility from treatment-induced hypergonadism.
Yes, and this is a massive trap for trainees. The fertility conversation has to start before any treatment happens.
Honestly.
It should happen at the very first consultation.
Often before the orchiectomy itself, right?
Exactly, because by the time these men are diagnosed, their baseline semen parameters are already highly abnormal.
Let's explain the biology there, because it's not a coincidence. There's this concept called testicular dysgenesis syndrome.
Right, the underlying developmental flaws.
Yeah, the exact same genetic or developmental flaws that predisposed him to the tumor also predisposed him to profoundly impaired spermatogenesis.
Let's break that down a bit. Testicular dysgenesis syndrome covers a spectrum. Cryptorchidism, which is undescended testicles, hypospadias, poor semen quality, and the cancer itself. It all goes back to fetal gonadal development.
Right, when the primordial germ cells don't differentiate properly.
Exactly. Maybe from genetic mutations or endocrine disruptors. The whole local architecture is compromised. The Leydig cells and Sertoli cells just don't function optimally.
So, the microenvironment that grew the tumor has been struggling to produce healthy sperm for his entire adult life.
Which means a lot of these men are severely subfertile at baseline. Some are totally azoospermic before we even touch them.
And if you don't tell them that up front and you check their sperm count after treatment, they're going to blame your radiation or chemo for a deficit that was already there.
Right. That's why the absolute ironclad rule for the boards is you must proactively offer sperm banking before initiating any gonotoxic treatment.
But let me push back on that standard dogma. Is it always just, bank your sperm before chemo or radiation? What if the timeline is tighter?
That's a great nuance. For most routine cases where the other testicle is totally normal, the window for banking is after the orchiectomy but before systemic therapy, or an RPLND.
The retroperitoneal lymph node dissection, right?
Yeah. But if the patient has no normal contralateral testis, maybe due to prior trauma, atrophy, or they already had an orchiectomy on the other side, then the banking has to happen before the orchiectomy itself.
Because in that specific scenario, the surgery is the gonotoxic event.
Precisely. You remove that single testicle, and you might push them into permanent sterility. So for the boards, say, if the orchiectomy itself threatens their only remaining source of fertility, facilitate sperm banking before the surgery.
Okay, so let's look at what the treatments actually do to the reproductive system, starting with our 29-year-old on active surveillance.
Well, surveillance is safe. It's inherently not gonotoxic. We aren't adding any iatrogenic fertility damage. He's only dealing with whatever baseline issues he had, plus the reality of having one functioning testicle instead of two.
Right. So to directly answer his question about trying for a baby, the answer is right now, today.
Exactly. There's no treatment-imposed waiting period for him.
They can try naturally immediately. Any banked sperm is just a backup. But what about guys getting cisplatin-based chemo?
Cisplatin is a heavy hitter. Multi-agent regimens like standard BEP therapy, so bleomycin, etoposide, and platinum, they commonly cause profound, severe azoospermia.
Because of the mechanism, right? The spermatogonia are constantly dividing.
Yeah, the germinal epithelium is highly mitotically active. Cisplatin works by binding to DNA and creating crosslinks that physically halt replication. Since those spermatogonia are dividing so fast, they just blindly absorb the cisplatin and get decimated.
And the key counseling point there is the timeline of recovery. The stem cells are damaged, but not always eradicated.
Right. Recovery happens for many men, but the timeline is notoriously unpredictable. It could be 2 years, it could be 5. Some never fully recover.
You definitely can't give them a rigid schedule. Now, what about surgery, the RPLND? How does a scalpel in the abdomen affect fertility?
It's a completely different mechanism. An RPLND does not threaten sperm production at all. The remaining testicle in the scrotum is untouched. What it threatens is the mechanical delivery system.
Ejaculation.
Yes. The process of ejaculation relies on a delicate sympathetic nerve plexus wrapped around the abdominal aorta and the inferior vena cava.
Right, those postganglionic fibers traveling down into the pelvis, they control emission.
Exactly. The reflex that propels the sperm into the posterior urethra. If the surgeon inadvertently damages those nerves during the dissection, the patient develops anejaculation or retrograde ejaculation.
So the sperm are being made just fine, but when he reaches climax, the bladder neck doesn't close and the sperm wash backward into the bladder.
Or the emission reflex just fails entirely. That's why modern nerve-sparing techniques are so critical. If they lose ejaculatory function, they can still father biological children, but it requires invasive surgical sperm extraction and in vitro fertilization.
And finally, let's talk about our specialty, radiation therapy. How does treating the retroperitoneal lymph nodes damage the healthy testicle?
It's best to teach this as a biological dose-response curve. When we treat the abdomen, the primary beam never touches the scrotum. The damage happens entirely via scatter dose.
Photons scattering inside the body or leaking from the linear accelerator.
Right. And the recovery of spermatogenesis depends on the exact cumulative dose of that scattered radiation.
So if it's very low, like a few tens of centigrade or CIG, the stem cells are stunned, but recovery might happen in a few months.
Yes. If it's an intermediate dose, say 50 to 100 centigrade, recovery is delayed for 2 to 3 years. And if the scatter dose creeps up toward 2 or 3 grays, you cause permanent azoospermia.
Which is why gonadal shielding, that physical lead clamshell we use, is an absolute ethical imperative.
Every single time you irradiate a para-aortic or dogleg field in these men.
I love thinking about gonadal shielding like a high SPF sunscreen. Imagine lying under an intense heat lamp, That's the primary beam. The shield doesn't stop the lamp from shining on your abdomen, but it acts like a thick layer of lead-lined zinc oxide over your most sensitive tissue.
I like that. It blocks the ambient heat, the low-dose scatter that is exquisitely toxic to the Sertoli cells.
Right. So we've covered fertility, but we have to pivot to a related physiological issue that is chronically undermanaged: hypogonadism.
Yes, testosterone production. People constantly conflate fertility and testosterone, but they're driven by two entirely different cell lines. Spermatogenesis relies on the Sertoli cells, which are sensitive to chemo and radiation.
But testosterone relies on the Leydig cells.
Exactly. Leydig cells are in the interstitial space. They aren't rapidly dividing, so they're relatively more robust and resistant to cytotoxic therapy, but they are not invincible.
And that nuance is why hypogonadism is undercalled. Because the Leydig cells are tougher, we assume testosterone will be fine. But even after orchiectomy alone, total testosterone can drop significantly.
You've suddenly removed 50% of the factory. The remaining testicle tries to undergo compensatory hypertrophy, but it might not perfectly compensate.
And then you add the systemic insult of chemo or scatter dose from radiation, and the risk of late-onset hypogonadism increases dramatically.
The clinical pearl here is you cannot wait for the patient to explicitly ask for a testosterone test. You have to listen for subtle symptoms.
Because these young guys are tough. They won't come in saying, my testosterone is low. They'll complain of profound, unexplainable fatigue.
Right. Or a subtle drop in libido, sudden erectile dysfunction, mood changes, increased irritability, or a noticeable loss of muscle mass despite working out.
Any combination of those should trigger an automatic morning total testosterone level check.
And it must be a morning draw, because testosterone have a diurnal rhythm. It peaks early. For your boards, a meaningful minority of these survivors will develop clinically significant low testosterone requiring a lifelong replacement.
You must continuously screen for these symptoms. So for our 29-year-old on surveillance, his fertility is intact. He can try for a child today, but we need to keep a highly suspicious eye on his endocrine health for decades.
Exactly. So that's the first question handled. But the reality is he won't be around to raise a child if we miss a microscopic recurrence.
Which changes the mood in the room entirely. How obsessively do we need to hunt for this cancer coming back? That brings us to question 2. How long do I need these scans?
The biggest trap trainees fall into here is trying to memorize one universal surveillance schedule. Testicular cancer is not a monolith. You have to separate the histologies.
So let's drop a simple mnemonic right now. Seminoma scans, non-seminoma numbers.
Seminoma scans, non-seminoma numbers. Perfect. Let's unpack the logic behind it. Why is seminoma follow-up driven by scans?
Because pure seminoma is generally a much more indolent, slower-growing tumor compared to the chaotic biology of non-seminomatous germ cell tumors, or NSGCT.
And crucially, pure seminomas do not reliably secrete robust tumor markers. They absolutely do not produce alpha-fetoprotein.
Right. If a biopsy says pure seminoma, but their alpha-fetoprotein is elevated, you must treat them as a non-seminoma.
Yes, because it implies there's a hidden yolk sac component the pathologist missed.
Mm-hmm.
Seminomas might produce a little beta-HCG in 10 to 15% of cases, but it's a weak tracking mechanism.
So the only way we can reliably detect a seminoma recurrence early is to physically look for it. We need cross-sectional imaging to see structural changes in the lymph nodes.
Hence, seminoma scans. So for our patient with stage 1 pure seminoma on surveillance, what does the modern guideline standard look like?
It's a highly organized schedule that runs strictly through the first 5 years. The backbone is history and physical exam, combined with rigorous cross-sectional abdominal imaging.
And the pacing isn't random. For the first 2 years, when the risk of early relapse is highest, imaging is typically every 6 months.
Then, in years 3 through 5, as the risk slowly tapers off, the scans space out to every 6 to 12 months, depending on if you follow the NCCN guidelines or the European ones.
Now think about the cumulative physical toll of that schedule. A CT scan of the abdomen and pelvis every 6 months for years. A standard scan delivers around 8 to 10 millisieverts of ionizing radiation.
Which adds up incredibly fast in a 29-year-old, and radiation exposure is a stochastic risk factor for secondary malignancies. Every single millisievert slightly increases the probability of a radiation-induced cancer decades later.
There is no safe threshold for stochastic effects, which leads to a major clinical pearl. MRI can absolutely substitute for CT imaging in these schedules.
Oh, that's a crucial board pearl. MRI uses magnetic fields, not ionizing radiation.
Right. If you're at an experienced center with radiologists who are adept at reading retroperitoneal lymph nodes on MRI, it's a fantastic way to drastically reduce radiation exposure.
It takes longer, it's more expensive, and it can be uncomfortable, but biologically, it's a tremendous advantage.
Okay, so that's what we do. Let's talk about what we absolutely not do, because the boards love testing overutilization.
Okay, let me play the role of the nervous new attending. My patient is terrified of a recurrence. The urge to order a PET scan for absolute peace of mind is huge. I ask you, why don't we throw in a PET CT scan once a year or routine chest CTS just to be safe?
I will stop you right there. If you say that in an oral board exam, you fail the scenario. A PET scan is never routine surveillance for early-stage testicular cancer.
But theoretically, PET is highly sensitive, right? It lights up cancer cells.
In theory, yes. But in a healthy young man's body, it's a diagnostic disaster. PET tracks a radio-labeled glucose analog called FDG. It looks for cells consuming massive amounts of glucose.
And what else consumes glucose in the abdomen? Inflammation, normal bowel peristalsis.
Exactly. Macrophages responding to a minor viral infection. Benign reactive lymph nodes. If you order a screening PET scan, you are statistically guaranteed to find a mildly avid glowing lymph node somewhere.
And then you trigger the terrifying cascade of false positives. You can't ignore the report. You have a terrified patient and you're legally forced to biopsy a benign node.
You subject him to surgical risk and psychological trauma for absolutely no oncologic reason. You've turned a survivor into a perpetual patient.
And the same logic applies to routine chest CT scans. The dominant landing zone is the retroperitoneum.
Chest imaging and markers are only used when clinically indicated by symptoms or findings. If he develops a new cough or you see something in the retroperitoneum, then you image the chest.
Not on a rigid schedule. Now let's briefly contrast this with the NSGCT schedule to finish our mnemonic non-seminoma numbers.
NSGCT is a much more aggressive, faster-growing entity. Relapses usually explode within the first year or two, and unlike seminoma, they reliably secrete alpha-fetoprotein and beta-HCG.
And those markers have short half-lives in the blood, 5 to 7 days for alpha-fetoprotein, maybe 24 to 36 hours for beta-HCG.
So we can track the microscopic volume of the disease in almost real time. NSGCT surveillance is incredibly front-loaded. It's very heavy on blood draws in that first year.
Early and marker heavy. So back to our 29-year-old, we track him through year 5. Clean MRI scans, normal testosterone, feels great. What happens at year 5 in one day?
Year 5 is a profound transition. The scheduled routine surveillance imaging usually stops entirely. The statistical risk of a late relapse drops off an absolute cliff.
The clinic visit fundamentally transforms. You aren't hunting for the cancer anymore, you're managing the survivorship.
Right, monitoring for decades-delayed consequences of treatments and managing holistic health.
To really understand why we scan the abdomen so religiously for 5 years, we need to transition into the failure patterns and anatomical geography.
This is where human embryology makes you a vastly better clinical oncologist. The testicles don't start in the scrotum. During fetal development, the gonads originate high up in the posterior abdominal wall.
Up by the kidneys, the mesonephros.
Yes, and as the fetus develops, the gubernaculum guides them down through the inguinal canal into the scrotum.
But they drag their blood supply and their lymphatic drainage pathways down with them. They leave a physical trail stretching all the way back to their origin.
Which is why the primary lymphatic drainage of the testicles is unlike any other pelvic organ. It bypasses the local pelvic nodes entirely. It takes a highway straight up to a high retroperitoneum.
So the dominant basin, the area we watch obsessively, is the retroperitoneal lymph nodes. Because of the venous anatomy, the left testes drains primarily to the para-aortic nodes.
And the right testis drains primarily to the interaorticatal nodes, between the aorta and the inferior vena cava. The high retroperitoneum is the first site of relapse.
And the lungs are the second, which anatomy also explains.
Yeah, as lymph fluid filters through the retroperitoneal nodes, it travels up the thoracic duct, which empties into the venous system near the internal jugular.
And the very next capillary bed that venous blood hits is in the lungs. So the cancer cells get trapped there.
But let me throw a curveball to test this logic. What if you're reviewing an MRI and you see a massive pelvic lymph node or an inguinal node, but the high retroperitoneum is totally clear?
That is a massive red flag. Isolated pelvic or inguinal nodal disease is highly atypical. It breaks the rules of embryology.
It usually suggests one of two things. Either the patient had prior surgery in the groin or scrotum like a hernia repair, or an improper transscrotal biopsy, which altered their lymphatic pathways.
Or they have incredibly advanced, bulky disease higher up in the abdomen that's physically blocking the upward flow, causing a retrograde flow back down.
Exactly. You cannot treat an isolated pelvic node as a standard progression. The same logic applies to brain and bone lesions. It's rare for testicular cancer to go there first without overwhelming disease in the abdomen or lungs.
If a patient presents with a new brain lesion but a clear abdomen and chest broaden your differential, it might be an unrelated primary tumor.
So, how do treatments alter this geographic map of failure? Our guy chose active surveillance. The natural relapse risk for stage 1 pure seminoma on surveillance is about 15 to 20% within the first few years,
But the salvage rate is nearly 100% with either salvage radiation or chemotherapy.
which is why surveillance is the preferred standard of care globally. We avoid overtreating the 80 to 85% of men who are already cured by the orchiectomy.
Right, but what if he refused surveillance and opted for adjuvant radiation therapy? We traditionally treat the periaortic strip to roughly 20 gray. What happens to the failure pattern? The overall relapse rate plummets to the low single digits, maybe 2 to 3%, but the geography shifts dramatically.
Because the treated periaortic strip is essentially sterilized by the 20 gray, relapses inside that field are rare.
So the new danger zones are just outside the edge of your radiation field, the untreated pelvic nodes just below, and the mediastinal or supraclavicular nodes just above.
The intervention physically altered the patient's risk geography. Now, what about adjuvant chemotherapy? Specifically, one single cycle of carboplatin for stage 1 pure seminoma.
Oh, this is a huge board trap. Residents always say if we give one cycle of carboplatin, the 5-year relapse risk drops to about 15 or 16%.
And that is fundamentally wrong. They are dangerously conflating two data sets. The 15 to 20% is the natural relapse risk if you do nothing.
If you give one cycle of adjuvant carboplatin, usually dosed using an area under the curve, or AUC, of 7, the risk drops to 2 to 5%.
Let's quickly explain AUC. It stands for area under the curve. It's a calculation of total cumulative drug exposure over time based on how fast the kidneys filter it out, using the GFR and the Calvert formula.
So an AUC of 7 is a substantial dose. It works beautifully to prevent relapse.
The debate isn't whether it works, it's whether it's necessary. Since surveillance has a salvage rate approaching 100%, many argue we shouldn't expose young men to systemic platinum toxicity when they didn't need it.
Before we leave failure patterns, we have to touch on late relapse. What if a relapse occurs at year 7 or year 10?
Late relapse defined as occurring more than 2 years after completion of primary therapy, but especially beyond 5 years, is a different biological beast.
It's rare, but notoriously difficult to treat. Highly chemo-resistant.
If you get a late relapse scenario on an oral board exam, the safest answer is, I would immediately refer this patient to a high-volume, multidisciplinary tertiary germ cell tumor center.
It's not something to manage alone in community practice. Surgical resection becomes incredibly critical, especially for NSGCT.
Because the tumor might have undergone malignant transformation into a mature teratoma, which is impervious to chemo, or a secondary somatic malignancy like a soft tissue sarcoma.
Both of which require aggressive surgical resection. Let's do a quick treatment planning pearl. As radiation oncologists, we are anatomical cartographers. Every field design decision, whether periaortic or dogleg, the total dose, the shielding, draws a permanent late effect map inside that patient.
That is a beautiful way to put it. We are deciding which healthy organs get low-dose scatter every day, dictating their risk profile for the next 50 years.
We dictate the fertility conversation, the stochastic risk of secondary malignancies in the kidneys, bowel, and remaining testicle. The technical details permanently dictate their survivorship burden.
Which brings us back to our 29-year-old, answering his third question. My older brother also had testicular cancer. Am I at risk for anything else now?
This pivots us perfectly into long-tail toxicity. Let's address his familial situation first. There's a remarkably strong familial component.
Brothers of men with testicular cancer have roughly an 8 to 10-fold increased relative risk of developing the disease. Fathers and sons have about a 4-fold increased risk.
So his family history means he needs to be hyper-vigilant about contralateral testicular self-exams. His genetic background puts that remaining tissue at high risk for a new primary tumor.
But, and this is vital, his family history does not give him a separate treatment-related toxicity profile.
Right, because he's on surveillance. He hasn't had systemic platinum chemo or scattered radiation. He isn't at elevated risk for radiation-induced sarcomas or cisplatin-induced neuropathy.
But let's look at the broader survivorship population. Men who did receive curative therapies in their 20s, what is the biggest cloud hanging over them in their 60s?
The profoundly elevated risk of second malignancies. Long-term registry data shows survivors exposed to therapeutic ionizing radiation or systemic platinum-based chemo have a statistically significant risk of developing unrelated solid tumors later in life.
And this risk is treatment-dependent and geographically dependent. If they received historical extended field radiation, they are at high risk within that anatomical portal. Stomach cancer, pancreatic cancer, aggressive sarcomas, transitional cell carcinomas of the renal pelvis.
And if they received systemic platinum chemo, the risk is diffuse leukemias or widespread solid tumors. You must stratify survivorship care based on specific treatment history.
What's the other major physiological system that takes a beating? The cardiovascular system. Cardiovascular disease is a primary leading cause of non-cancer mortality in these survivors.
And it confused me in residency. You think the chemo washes out, the side effects stop, but cisplatin permanently alters the vascular endothelium.
It accelerates atherosclerosis years later. It leaves a legacy of endothelial dysfunction. And these patients frequently develop a severe metabolic syndrome, weight gain, chronic hypertension, hyperlipidemia, insulin resistance.
So checking blood pressure, ordering fasting lipid panels, checking hemoglobin A1C, and aggressively counseling on heart-healthy diets and exercise, these are mandatory life-saving oncology follow-up requirements.
You are actively trying to prevent a fatal myocardial infarction at age 50. Let's drill into specific drug toxicities because the boards love mechanisms. Starting with cisplatin, it leaves a specific fingerprint on the nervous and renal systems.
As a heavy metal, it accumulates outside the blood-brain barrier, specifically in the dorsal root ganglia of the spinal cord. This causes dose-dependent sensory peripheral neuropathy.
A stocking glove distribution of tingling, numbness, or burning pain in the hands and feet. It also attacks the inner ear. It accumulates in the dorsum vascularis, leading to apoptosis of the outer hair cells in the cochlea.
Which manifests as high-frequency sensorineural hearing loss and chronic tinnitus. And it's often permanent. Cisplatin is also notoriously nephrotoxic.
It damages the proximal tubules, leading to chronic renal dysfunction, and can cause Raynaud-type vascular spasms in the cold.
Okay, what about bleomycin, the B in the BEP regimen, famous for one terrifying toxicity?
Culinary fibrosis. Bleomycin binds to DNA and iron, forming a complex that generates massive free radicals with oxygen. An enzyme called bleomycin hydrolase normally breaks the drug down.
But the lungs and skin have remarkably low levels of bleomycin hydrolase, so the drug accumulates there, generating oxidative stress, triggering macrophage activation and fibroblast proliferation.
Leading to thick, stiff lungs that cannot exchange oxygen. It literally suffocates the patient.
And the highly testable board pearl here is about elective surgeries. The old dogma was, never be exposed to high concentrations of medical oxygen again.
They feared high fraction of inspired oxygen, or FiO2, during general anesthesia would trigger an explosion of free radicals, causing a delayed acute respiratory distress syndrome, or ARDS.
But teaching an absolute lifelong oxygen ban is practically impossible. If they're having a massive heart attack, you can't withhold life-saving oxygen.
The modern nuanced pearl is, the patient must advocate for himself. Before any surgery, he must explicitly inform his anesthesia team of his bleomycin history.
The anesthesiologist will keep the FiO2 as low as safely possible, aiming for saturations in the low 90s, and meticulously manage intravenous fluid administration to prevent pulmonary edema.
So putting it all together, what does a comprehensive survivorship clinic visit look like?
First, rigorous cardiovascular risk assessment. Blood pressure, lipids, glucose, body mass index. Second, directly inquire about symptoms of hypogonadism. Check a morning total testosterone if indicated.
Third, if they had cisplatin, review hearing status, assess peripheral neuropathy, and monitor long-term renal function with serum creatinine and GFR.
Fourth, if they had bleomycin, ensure they know the script for their future anesthesiologists. Fifth, relentless primary prevention, smoking cessation, intense exercise, healthy diet.
And finally, ensure their primary care physician is deeply integrated into the team. The oncologist cannot be the only doctor managing this patient for 40 years.
Notice what isn't on the checklist. No routine whole-body CT or PET scans hunting for second cancers, just standard age-appropriate screening guidelines.
All right, time to synthesize this into rapid-fire takeaways for the oral boards. Let's start with the 3 major catastrophic traps.
Trap 1. Swapping a pure seminoma schedule with an NSGCT schedule. Remember the mnemonic. Seminoma scans, Non-seminoma numbers. Seminoma is indolent and requires structural imaging. NSGCT is fast and relies heavily on tumor markers.
Trap 2. Overordering tests for a pure seminoma surveillance patient. Do not volunteer routine chest imaging, frequent unnecessary tumor markers, and absolutely no routine screening PET scans.
Trap 3. Talking at length about the cure without immediately pivoting to the long-tail issues. You must proactively volunteer details on endocrine health, cardiovascular risk, specific late effects, and secondary malignancy risk.
Okay, let's do the board blitz. I'll ask you walk through the exact reasoning. Question 1. What primarily drives the follow-up cadence during stage 1 pure seminoma active surveillance?
Cross-sectional abdominal imaging. Seminoma scans. The tumor doesn't secrete reliable protein markers and grows indolently, so we have to look for structural anatomical changes in the dominant lymphatic relapse basin, which due to embryology is the high retroperitoneum. I would order a CT of the abdomen and pelvis every 6 months for the first 2 years, or preferably substitute an MRI to spare the ionizing radiation dose.
Perfect. Question 2. True or false? One cycle of adjuvant carboplatin for stage 1 pure seminoma carries a 16% 5-year relapse risk.
Absolutely false. That conflates two data sets. 15 to 20% is the natural relapse rate on active surveillance. If you administer one cycle of adjuvant carboplatin dosed appropriately at an AUC of 7, the relapse risk is massively reduced to the low single digits, around 2 to 5%. The debate is about necessity, not efficacy.
Excellent. Final question. A testicular cancer survivor cured with multi-agent BEP chemotherapy 10 years ago now needs elective orthopedic surgery for a torn ligament. What is the absolute key survivorship pearl you need to ensure is communicated?
The critical issue is his prior exposure to bleomycin. Because his lungs lack bleomycin hydrolase, he is at a severe risk for catastrophic pulmonary toxicity if exposed to high concentrations of medical oxygen. The surgical anesthesia team must be explicitly informed. This allows them to carefully titrate the FiO2 to the absolute lowest safe level to maintain oxygenation and to manage intravenous fluids meticulously to avoid pulmonary edema.
Spot on. That demonstrates mature clinical judgment.
So bringing this whole deep dive together, we started with a 29-year-old man who thought his journey was over. But in testicular cancer, the initial cure is really just the starting gun for the long survivorship clock.
Getting the surgery right and instituting the correct follow-up is critical. But the real work is managing the consequences of our interventions. Proactive fertility counseling, understanding embryological geography.
And the decades-long management of endocrine failure, cardiovascular disease, pulmonary fibrosis, neuropathy, and secondary cancers. You're safeguarding an entire human life. When you head back into clinic tomorrow, ask yourself, am I just looking at the scan or am I looking at the man?
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.